If you've been told you may need neck surgery, or you're researching what anterior cervical discectomy and fusion really means, you're in the right place. I believe that when patients truly understand what's happening in their body and how surgery can help, they approach it with more confidence and peace of mind. Unfortunately, most people only hear the scary version, such as spine surgery or fusion or hardware, without the context that explains how safe and effective this procedure really can be. I'm Dr. Richard Hurley, a board-certified orthopedic surgeon who has completed a spine fellowship. I've helped hundreds of patients with cervical disc problems regain strength, balance, and quality of life through procedures like anterior cervical discectomy and fusion. In this video, we'll go step by step through when it's used, what happens during surgery, the benefits, the risks, and the alternatives you should know about before making a decision. ACDF stands for anterior cervical discectomy and fusion. It's one of the most common and reliable surgeries we perform on the neck. It has been performed for decades, but there have been modifications and improvements to the originally described approach in the 1950s. We usually recommend ACDF when patients experience the following: cervical radiculopathy, or nerve compression causing arm pain, numbness or weakness; cervical myelopathy, which is spinal cord compression leading to balance or coordination issues; persistent symptoms, when therapy, medications, or injections haven't helped after 12 weeks; progressive weakness or instability, when nerve damage or spinal instability worsens over time; trauma, such as fractures or ligamentous injuries requiring stabilization. In short, ACDF relieves pressure on the nerves or spinal cord and locks the affected area in a stable, pain-free position so you can move forward safely. So if you're wondering what actually happens during this surgery, let's walk through it. The word anterior means we approach from the front of the neck, not the back. Through a small incision, we gently move aside muscles and soft tissues to reach the spine. The damaged disc is then removed. The nerves are decompressed along with the spinal cord, and a small implant, often with bone graft material, is placed in to restore height and lordosis and promote fusion. A small plate and screws are then added to stabilize the area while the bones heal. Some surgeons even use integrated fixation devices which do not require plate fixation. Think of it like removing a worn-out cushion between two blocks and then replacing it with a sturdy, supportive one that locks things into place, restoring alignment and stability. And for the right patient, the results can be very life-changing. When performed for the right reason, ACDF has decades of data supporting its success. For instance, there's been relief of arm pain in 70 to 90% of patients, experience significant improvement. Neurologic recovery, weakness and numbness improve or stabilize in up to 90% of cases. Stability, the fusion prevents painful motion at the operative level. Durability, results often last for years and there are high satisfaction rates. This procedure has stood the test of time, not because it's old-fashioned, but because it actually works. Modern implants and techniques have only made it safer and more precise. Of course, even with a proven surgery like this, it's important to know there are possible risks. Like any surgery, ACDF carries risks, but most are temporary or manageable. These risks include difficulty swallowing, also known as dysphagia. This is common early in about 9 to 21% of patients and usually improves with only 3 to 5% persisting long term. And I counsel patients that you will have some difficulty swallowing after surgery, but if this is your first time having this operation, that risk is low. If you have had multiple neck surgeries performed previously, then your risk is higher. And in those patients, I will order swallowing function studies preoperatively to assess swallowing function and to prevent dysfunction after the operation. Hoarseness. This is usually temporary if it occurs at all, and when it does happen, it's about 2 to 7% of cases. It can be permanent in about 1% of cases. Again, this is typically seen more commonly in patients who have had prior neck surgery, and I will order video strobolaryngoscopy in those patients to help assess vocal fold motion and make surgical adjustments to prevent injury whenever possible. Infection. This is rare and happens in less than 1% of cases. Dural tear. The covering around the spinal cord or the nerves can be injured, leading to a leak of cerebral spinal fluid at the time of the operation. This does require repair. Persistent leaks are rare, but can happen. Non-union. This is frequently dependent on the number of levels fused, the type of plate fixation, the length of the screws, the implant or bone graft material, but in general, the rates are low at 5 to 15%. Higher in smokers or multi-level surgeries. Adjacent segment wear. About 2 to 3% per year is what we see after this surgery, and this is cumulative. It is not known whether it is the stiffness of the fusion that causes this phenomenon or the fact that the spine has to compensate and make up for lost motion at a given level, but adjacent segment disease is a risk and one of important significance. Serious complications like nerve or vascular injury are extremely rare, well under 1%. There are multiple vessels that are present in the neck, and they need to be protected during the surgery with a retractor. Your surgeon will review your MRI and other images very closely before surgery to protect these at the time of your operation. Your spinal cord and nerves also need to be protected, and I routinely use something called neuromonitoring to help me do so. General surgical risks. As with any operation, there are small risks associated with anesthesia. There's also blood clots that can form, and and there's other medical complications that can happen. The key takeaway, most patients do very well. When performed by an experienced team, anterior cervical discectomy and fusion is safe, predictable, and it's a durable procedure. Not everyone with neck pain needs surgery. So let's talk about alternatives. Before surgery, we always exhaust non-surgical treatment options. These can include physical therapy to improve posture, to improve strength, or even flexibility, medications to help reduce inflammation or nerve root irritation. Epidural steroid injections can also provide temporary relief and decrease inflammation around nerves. Other surgeries, such as cervical disc arthroplasty, are motion-preserving options for some patients instead of a fusion. I frequently perform this operation and find that it is a very reliable alternative to fusion, but it requires special counseling and additional imaging studies to ensure that this surgery is a good fit. Surgery is a very powerful tool, but it's just one of many. The best choice depends on your specific anatomy, your lifestyle, and your goals. If ACDF is right for you, here's the key point to remember. To recap, ACDF is a time-tested, reliable procedure for relieving nerve or spinal cord compression in the neck. It helps patients with radiculopathy, myelopathy, or instability find lasting relief and stability and improve function. The goal isn't just to fuse the spine, it's to free the patient from pain and restore their confidence in movement. If this helped you understand ACDF more clearly, please like the video, subscribe for more educational spine content, and drop your questions in the comments below. I read every one. I'm Dr. Richard Hurley. Thank you for watching, and take care of your spine.